Good afternoon, everybody, and thank you for joining the webinar this afternoon. We're just waiting for a few more people to join, and then we'll start. Thank you. Okay, so good afternoon to everyone once again, or good morning, depending on where you are in the world today. And welcome to our webinar on emerging research and practice on gender-based violence in the time of COVID-19. My name is Dr. Leanne Ramsumar, and I'm a public health researcher and research uptake specialist in the Gender and Health Research Unit at the South African Medical Research Council. We're very pleased that you're able to join us today. And this webinar is hosted by the Gender and Health Research Unit of the South African Medical Research Council, which has a 25-year history of high impact research on gender-based violence in Africa and in the Global South. So we're very pleased to be hosting this webinar this afternoon that will highlight both research and practice that has been underway on gender-based violence in the current COVID-19 reality. Just by way of what to expect, the webinar will be structured as follows. We're going to have two presentations by leading researchers from within the Gender and Health Research Unit. And then we're going to have an in-conversation chat with two leading prevention programmers in the field of gender-based violence in South Africa. So an opportunity for a rich discussion and deliberation this afternoon at what I think is a very timely and relevant topic in South Africa, but also globally. So once again, I want to welcome you and thank you for joining us, and also to remind you that this webinar is going to be quite interactive. And so you will, as participants, have an opportunity to engage in a question and answer session, which will be available to you in two forms. Ideally, we would like for you to use the Q&A function, which you will find at the bottom of your Zoom screen. And if you can type in your questions as each of the presentations are done, we will have a moderated question and answer session at the end, led by my colleague, Dr. Nwabisa Shai. So please do feel free to write in your questions throughout the course of this presentation and webinar, and we will address them at the end. The Gender and Health Research Unit has a rich history of having done both research as well as collaborating with practitioners of gender-based violence prevention and response over the last 25 years. And we're also very privileged to have some of the key leading gender-based violence experts in the country, and of course of global caliber. And so I want to introduce the first speaker to you today, which is my colleague, Dr. Pinky Mahlangu. Pinky is a specialist scientist at the Gender and Health Research Unit at the SAMRC, and an honorary lecturer at the School of Public Health at the University of the Witwatersrand. Her research has focused on the prevention of gender-based violence, with a focus on particularly young women and adolescents, and on the development and adaptation and evaluation of evidence-based gender-based violence interventions low and middle income countries. It's indeed my pleasure to introduce what the MRC has recently featured as one of the go-getters within the Gender and Health Unit and within the MRC more broadly. Over to you, Dr. Pinky Mahlangu.
Thanks, Leanne. Good afternoon, everybody. So this afternoon, I'll be presenting on the research that we've conducted as the Gender and Health Research Unit of the SAMRC. And the research was exploring the link and impact of COVID-19 and the lockdown to gender-based violence, mental health, and livelihoods amongst selected population groups in South Africa. Next slide, please. So the aim of the research was to understand the impact of COVID-19 pandemic and the lockdown on family dynamics. We were specifically interested to understand how the COVID-19 and the lockdown has impacted experiences of violence against women and children, and the underlying factors influencing these dynamics in the home. And we asked about what we know are the key factors associated with IPV and violence against women and children. This includes mental health, livelihoods, income, and the other factors that you will see in the presentation. We were interested to see how COVID-19 has impacted on different socioeconomic groups. And we used the Stats SA income bracket to classify men and women in the community. We selected men and women who are unemployed, those within the low income bracket, the medium income bracket, and we wanted to see differences amongst all these groups. And only men and women who were 18 years and above were selected to participate in the research. Thanks, Leon. Thanks, Leon. We recruited our participants over an advert which was posted on SAMRC social media platforms. As the research team, we then shared the advert in our Facebook page and also called the field workers who used to work with us to share the advert with their contacts, just to make sure that we communicate the message across and not only amongst the people that we know. Participants who were interested were requested to send a WhatsApp message, a text, or an email to indicate their interest. Excuse me. The first call, after we received the SMS, we then did a first call where we screened participants to make sure that they stay in Gauteng. And we wanted to make sure that they are living with a spouse and all children. We also wanted to check and ensure that we include those who were living in Gauteng during February, because we were interested on the impact of the hard lockdown, the first 21 days lockdown. And then we also, during that first call, took our participants through the informed consent process. And then after that, we requested them to send us a written consent via WhatsApp, text, or email. This was a qualitative study where we conducted in-depth interviews that lasted about 35 to 60 minutes. And these interviews were conducted by the research team that you saw on the first slide. We had ethics approval from the SAMRC, and we emphasized during the screening and also when we started the interview about privacy and confidentiality. We asked participants to specifically select a day where they will make sure that they have a private space where they can take the call. And we also assured them of the privacy and of the confidentiality of the data that they'll be sharing with us. We reimbursed them an amount of 100 rands via e-wallet. Next slide, please. Okay. Thanks, Patrick. So these are our participants. Though we were targeting 40 participants, 20 women and 20 men, we needed to make sure that we have 10 women from the low socioeconomic class and no income, and then 10 women from the high and medium income group. We have so far conducted 33 interviews, and we are still to complete the interviews. Today, I'll be presenting on the 33 preliminary data from the 33 interviews that we've conducted. In terms of timing, we conducted these interviews during level 3 lockdown, and we did this to ensure that at that time, participants would have privacy because restrictions were kind of relaxed a bit. We wanted to make sure that they'll have private space to take the call. Some of them, as you can see on my slides, most did these interviews under level 3, and we had 5 that were interviewed in level 2. Next slide, please. These are the findings now. I'm starting the findings slide. In terms of the perceptions about risk of acquiring COVID-19, both high and low SES participants recognize their risk for contracting COVID-19. However, people in the high SES consider themselves less likely to contract COVID-19 compared to those in the low SES. And please, when I say high SES, this includes both high and medium, and the low SES includes the ones that the no income group. In these quotations, the first quotation, it's an example of a man who was working for government, who explained the differences in terms of the risk, explaining that he feels he's not at risk because he's able to work at home. He is no longer traveling as before, as it was before COVID-19, and also the kids are at home. So he felt that even his location where he stays kind of allows him to social distance, to stay at home, and to reduce his risk of contracting COVID-19. Amongst those in the low SES, participants associated their risk to their living conditions and also their workplace arrangements, explaining that because they have to travel back from home and to work, they feel that they are more at risk to acquire COVID-19. Others explaining that their situation does not allow for them to stay at home during that time because they need to go out so they can earn an income. Adherence to lockdown was generally different across communities, though most of them recognized the need of the lockdown. Our data shows that different communities adhered differently compared to the others, and people spoke about ignorance, that they feel that some people are ignorant, and this was not only amongst the low SES, it was across the different income groups. They also spoke about the fatigue, that as the lockdown started, they were adhering to regulations, but as the days continued, they found themselves not adhering as they used to. And there was also a general perception that some of these measures were unrealistic and biased towards those who can socially distance, based on the space and the class privilege that was explained by our participants. They felt that those who stay in places that are not so densely populated were kind of the ones that the president and his committee were thinking about when they set these regulations. They also felt that it did not consider some of their living conditions, the one in the low income groups. For example, one man made an example and asked, how can my child social distance, not go to the streets when I have nothing to keep them in the home so that they do not go out? Another woman explained that at that time, domestic workers were not allowed to go to work, but she says that she went to work because she felt that she cannot stay at home. The husband is not working. If she stays at home, how are they going to buy food? So she needed money to be able to buy food, and because of that, she couldn't adhere to the regulation of staying at home. Generally, people in the high income brackets spoke about being inconvenienced by the lockdown. They spoke about being confined in one space and not being able to move around. They spoke about their plans being disrupted. Weddings had to be postponed. Some had to cancel their holiday plans. But really, they acknowledge that some of the things are the pleasurable, leisurely things that really they did not lose anything out of them, like going out to eat, those kinds of examples that were shared with us. However, people in the low income group reported being confined in congested spaces. They experienced food shortages, and many of them spoke about losing the loss of hope for the future, because as they saw family members, friends being retrenched, they felt that their plans or hopes for getting a job or getting employment were reduced by day. And for them, they said that it was really, really bad to be able to stay at home hungry, where you are congested and there's 8 more people that are staying around you, and you are staying. Some people even gave an example that I live in a 2-roomed shack. How do you expect that all of us will be in the house when we don't have food at that time? So those were the differences in terms of the experience of the lockdown amongst them. We've also found that the lockdown had an impact on the income and livelihoods in families. Few people from the high income group reported having had their income changed. Most of them said the income was not affected at all, and often these were people who were working for the for government. There were, however, differences in how COVID-19 has impacted spending in their homes. While some spoke about having saved because they no longer travel to work, because they no longer buy cigarette. There was cigarette ban, alcohol ban. They no longer have visitors during the weekends. They felt that that allowed them to save at that time. Others, though, spoke about their expenses having increased dramatically and that they eat more. There was one who said because of the boredom and the confinement, they even had to get a dog so that, you know, it can take away the boredom. They also spoke about electricity bills having gone up, water bills having gone up during this time as they spent most of their time at home. Amongst the participants in the low SES, many families spoke about having experienced either retrenchments, pay cuts, or loss of the temporary jobs that they had. They also did mention that their spending was affected a lot. One woman explained that now she works 2 instead of the 5 days a week that she used to do. And she was really worried how she's going to afford sending back the child to school when schools reopen. They also indicated that as much as the budget is now less, but they eat more because they spend most of the time at home. Those who are unemployed, even those who had their salary cuts, they explained that they now depend on government grants or they borrow money from family members or their friends. Mental health issues were really across the different groups, and most people spoke about anxiety, stress and depression, stress over loss of jobs, having less income, anxiety of acquiring COVID-19. Those who had contracted COVID-19 spoke about the stigma that has been associated with that and how that impacts on their mental health. There was a lot of mention about stress of balancing work and childcare amongst those who are working. Depression as a result of confinement. People were frustrated about the inconsistent grant and food parcels that they've been getting. There was lots about depression reported by the parents amongst their adolescents who suddenly spends most of their time locking themselves in their room, worried whether they'll be able to complete the academic year, whether they'll be able to go to school. Also amongst the parents, there was fear that what if my child no longer wants to go back when schools reopen? So they felt that that has kind of disrupted the routine that the children had before COVID-19. There was lots of mention of tensions between spouses over not having food, having less money to spend. They felt that this created tension in the household. There were lots of arguments between spouses over this. One woman mentioned that she find it very difficult because every day she has to ask, what are we going to eat? And she knows that that will bring a heated argument between between her and the spouse. Some men reported being angered and felt that their masculinity was being questioned when the spouses struggled to provide as they normally did. And this did lead to uncomfortable exchanges between them. And they felt that the woman, because the woman does not understand, this man here from the low income group, he felt that he had to make sure that she understands. And all of that kind of brought tension in the home. And he says that he knew that sometimes he was using strong words, but he would apologize for that after he has done that. A few women reported emotional abuse. Majority, though, said they did not experience any form of violence. And those who experienced emotional abuse spoke about having husbands who are at home, no longer working or having less money, and how that contributes, make them to be more angry or depressed, and having to deal with that was emotionally difficult for them. In terms of the children, some of the mothers felt that they had the high levels of stress due to COVID-19 related factors has caused them to be more impatient, to be aggressive towards their children. Some even disclosing that I did hit them, and I feel my temper is, I lose my temper, and I end up, beating the child. So I can't wait for them to go back to school. Again, here we had very few who reported their experience. Rather, they reported experiences of other people from other families. And this woman here was talking about case of violence which have happened in the homes and have been reported in the church where she volunteers. But overall, she was saying that COVID-19 was like a spark. It kind of exposed some of the hidden violence that is happening in the homes. Now they were reported more during this time of COVID. Others spoke about seeing children playing on the streets without masks, not supervised, and they were concerned about what would happen because of that. Some methodological insights from the process. We've learned that it is difficult to establish rapport when you're conducting interviews over the phone with no visual cues, where you can learn how the participant is feeling and adjust accordingly. Some of the people wanted to do the interview quickly. We had that sense of being rushed when we were doing the interviews, which is not something we experience often when we are face-to-face. It was also difficult, as much as we emphasized privacy during screening, beginning of the interview, but it was really, really difficult to ensure privacy so that we can enable participants to open up and share. And in some instances, we could even overhear someone speaking in the background, either a child or another voice. And when we were asking one man about whether violence has happened in his home, he said that it did happen, but he couldn't explain because the wife was there at the time. He just said, I cannot talk about it. My wife is around. We also learned that there was, people were happy and free to talk about anything, but there was resistance when we asked IPV questions. They were not comfortable to talk about violence. There was hesitation, tone change, and people would just want to move quickly from that and say, no, nothing bad happened. We also found that some women would rather, many of them actually, would rather talk about other people's experiences of IPV or child abuse. Instead, they gave us a good picture about their marriage or about their husbands. Men would rather talk about tension. When we try to probe further about violence-related questions, they wouldn't want. They'll just say, we had small tension, but nothing bad. So really, there was. We found it really, really difficult to get people to talk about their violence experiences. So in conclusion, our study has kind of highlighted these contrasting experiences and impact of COVID and the lockdown. And these were dependent on socioeconomic status, the living conditions, the employment conditions for different socioeconomic groups. But also, the COVID-19 has kind of confirmed some of the existing inequalities in our society and shown that most of them were likely exacerbated by this COVID-19 and the lockdown. Also highlighting some of the long-lasting impacts which we feel require interventions such as mental health, the loss of hope that we found or was shown in our data. We also learned, though, that there were some positive impacts noted in some families having bonded over this time, having spent more time with their spouses and with their children and with their families. We also learned of some of the methodological issues that we noted in our research that, as a field, we need to improve how we conduct violence against women research remotely. For us, this was the first study that we did, and we learned of all these challenges and conclude that we do need to deepen our knowledge on how we conduct violence against women and children research, making sure that we conduct it in a manner that will be safe to our participants, but also creating conditions that will enable and encourage our participants to disclose of their experience of violence. Thanks, Leanne. I'm sorry I took some more time, but I will hand over to you. Thanks very much.
Thank you very, very much, Pinky. That was really very enlightening, particularly because I think it's one of the first studies that have been done during COVID-19 in South Africa. So really provided some very valuable insights. One of the things that struck me about your presentation is, and we've been hearing about a lot, is how COVID has highlighted the existing inequalities in South Africa, but also how it's deepened them for the future. And I wonder if you just want to quickly tell us how future interventions around gender-based violence can address some of these.
Okay, I think in terms of the inequalities, that would be, you know, it's a long-term process that would not, it's not something that can be done now. But I think issues of mental health and loss of hope, definitely interventions can be done around that, because, you know, our research kind of created space for people to debrief. It was interesting to see them being forthcoming, being willing to talk about how stressed they were, how their income was affected. So we felt that if such interventions can be provided for people, where they'll have space to talk and debrief about this, and also find support in terms of moving forward and dealing with those experiences, to make sure that they don't have long-term impacts on their lives.
Awesome. Thanks so much for that, Pinky. And great insights. I think also one of the things that we're thinking about, all of us have been preoccupied with is how we would try to account for some of these inequalities and structural factors in the current COVID reality. And I think our next speaker will touch on some of that. I want to introduce you now to Professor Rachel Jukes. She needs very little introduction. She's an A-rated scientist who has made her career from researching gender-based violence and the intersections of gender inequality and health. She was formerly our director at the Gender and Health Research Unit, which is now headed by Professor Naima Abrahams. Rachel currently occupies the position of executive scientist for research strategy and the intramural units of the South African Medical Research Council. Welcome, Rachel, and thank you for joining us this afternoon.
Thank you very much, Leanne, and good afternoon, everyone, and thank you for joining us for this webinar. So I want to share a few thoughts around prevention of gender-based violence in the time of COVID, building on what has come across sort of indirectly, and I think through hints and silences within some of the research that Pinky has just shared with us. Next slide, please. So I think that the key thing is that we do know that gender-based violence has increased in prevalence during COVID-19 in many countries. And we also are in a situation where prior to COVID-19, there was an evolving body of knowledge about the effectiveness of interventions to prevent violence against women and girls, and what features are needed to be effective. So what I really want to do is to share some of this information with you and to discuss and help us start reflecting on how we adapt interventions so that they can be delivered safely in the context of COVID. Next slide. So what do we know about the increase in prevalence of gender-based violence? We've seen reports from across the world, from China to the Eastern Mediterranean, Europe, USA, across Latin America, about increases of perhaps 20 to 30% in intimate partner violence, with worrying increase in femicide. There hasn't been very rigorous research conducted in any of these countries, but the consistency of the reports sends a strong message to all of us. In South Africa, we've been able to drill down a bit further, and we've seen a mixed impact of lockdown on gender-based violence. It's been interesting because some forms have probably decreased. Like there's fairly compelling evidence that at least during the period of level 5 and 4 lockdown, rape reduced and actually massively reduced. and in a way that makes sense when we think about sort of major contexts of rape that require interaction outside the home. Obviously, some rape didn't reduce, and particularly a component within the home we wouldn't expect to have at all. We also know that reports to the police of domestic violence fell considerably, but we know that reports from the police are an extremely crude way of assessing what's going on with domestic violence in our society. Far more reliable are the reports from NGOs that provide support for women survivors that point towards large increases in intimate partner violence. Next slide. So the key question for us all is, what do we do about this? Sorry, can I have the... and I would say that understanding the impact of COVID on IPV requires us to understand the drivers of violence. Next slide. In this next slide, I'm showing an image that presents information on the drivers of violence, and really understanding why IPV has gone up requires us to understand this. There are two key groups of drivers of violence. One are the structural factors, and we know that centrally placed here is gender inequality, patriarchal privilege, and the disempowerment of women, which is the root of the problem of gender-based violence, including femicide, within our society. Integrally linked to this is a normalization of the use of violence in a whole range of different forms of social relationships, starting with child rearing, but stretching across the life cycle: peer violence, violence in gangs, violence in neighborhoods, violence enacted against people viewed as criminals, violence against staff in hospitals, violence by teachers against pupils, and so forth. And violence is normalized in our society. It's obviously strongly gendered violence, whether it's directed by a man against one particular woman in which he has a relationship, or in non-partner rape. But even in other forms of violence, it very much is an enactment of power, and normally in the perpetuation of patriarchal power. Violence is integrally linked to poverty. And much as we know that violence occurs across social groups in our society economically, it is much more severe in areas that are poorer, and low education and food insecurity drive violence. Both of these structural factors feed into and drive our individual level factors. And so the tensions that arise, for example, from trying to live and raise a family in poverty often are translated into poor communication and relationship conflict responses, escalating anger to the use of verbal and then physical violence during contexts of conflict, for example. The circumstances of gender inequality and poverty fuel poor mental health and substance abuse, particularly as they interact with exposure to violence, which is one of the very, very important risk factors for poor mental health and substance abuse of both men and women within our society. And childhood neglect and abuse, which is one of the most potent forms of violence exposure, leading to impact on the whole trajectory of the relationship of individuals with violence, whether women as future victims of violence or men as future perpetrators. And we also know that violence is much more highly prevalent as an experience amongst women who are disabled, at least twice as highly prevalent. So these structural factors interact with the individual and relationship level factors to fuel intimate partner violence. And I've put at the top, because this model is based on an analysis of our global literature, armed conflict and post-conflict. And this comes across very clearly in some settings driving violence. But I want us to remember that in South Africa, it's only 25 years since the end of apartheid. And the last 2 decades of the struggle against apartheid was conducted in a way that resulted in widespread and escalating firearm availability within communities and violence within communities. And the legacy of that persists to this day, and the problem of gun ownership and weapons within our communities and how those intersect with violence overall and are used to harm women and children. And particularly when we look at the question of femicide and we look at the question of guns involved in rape, is a very, very important one for us to tackle. So obviously not all of these risk factors are escalated by COVID. So let's look at the ones that are. Poverty, low levels of education. We've seen this massive decline in the economy during the time of COVID. Next star, please. Poor communication and relationship conflict responses, escalation of stress, either due to poverty or due to lockdown overall or concerns about job losses, will fuel conflict within relationships. And the last star, and poor mental health and substance abuse, which are key drivers. And so when we try and understand the impact of COVID and how it may have escalated partner violence, it's critical for us to understand these particular drivers of partner violence which are impacted on by the epidemic. Next slide. So our challenge is to implement programs that are effective in addressing the drivers of violence, with particular emphasis on these COVID exacerbated drivers. So a key question is what works. And in the next slide, I'm going to present you an image that comes from the report that I've shown on the left here, which is available on our website, whatworks.co.za, which has all the publications from the What Works to Prevent Violence Against Women and Girls global program. Next slide. So in this next slide, what I'm going to show you is the findings of a critical review of what has been shown through rigorously conducted research to impact on women's experiences of physical and or sexual intimate partner violence. And this really summarizes what's known in the field of gender-based violence prevention. And what we see in the top blue strip is that there are now 9 different types of interventions which have been shown to be effective in preventing violence when the interventions are well designed and when they're well executed. And we see mapping onto our drivers of violence the fact that 2 of these have centrally placed economic interventions, economic transfer programs, that's cash transfers, and combined economic and social empowerment programs targeting women. Whether these programs are combining gender empowerment component with an income generating activity, or whether there is some other form of economic component like microfinance targeting women. There's research showing that parenting programs that prevent IPV and child maltreatment, particularly when delivered around the birth of a child and involving fathers, can be effective. Research showing community activism interventions to shift harmful gender attitudes, roles and norms can be effective. These are long-term interventions. School-based interventions delivered outside the normal curriculum to prevent dating and sexual violence. School-based interventions to prevent peer violence. We've also seen that interventions that work with individuals and couples to reduce alcohol or substance abuse are effective, as well as couples interventions looking at transforming their gender relations. And I want to flag interventions with sex workers because they're a particularly high-risk group. And we see that interventions have been designed to empower them or collectivize them and tackle alcohol and substance abuse, which are common problems, have been effective in reducing violence experienced from clients, police, and strangers. And then there are other interventions discussed in this report where there is rather less evidence or the evidence is conflicting. But we have this solid body of 9 types of interventions. And if you can press again, Patrick, I think our key challenge is for us to say, we have a good idea of some of the things that work. And so now what we need to do is go out and implement them. Next slide. But one of the key things about these interventions is that they're effective when they're well designed and implemented. And so I want to just talk to you about what that really means. And again, the report on the left, which is available on the What Works website, has information about this and how we've reached these conclusions. Next slide. So we've identified through drilling down across the evidence base, which was conducted in studies across 13 countries of Africa and Asia, what we've concluded what are the design and implementation features that make interventions more effective in gender-based violence prevention. And there are 10 of them. So the first is that interventions need to be rigorously planned with a robust theory of change rooted in local context. They need to tackle multiple drivers, such as gender inequality, poverty, poor communication, marital conflict. They don't need to tackle every single driver of violence within one intervention, but they do need to address multiple ones. We need to work with women and men, especially in highly patriarchal contexts, and where relevant, we may need to work with families. And that's something we haven't explored in South Africa overall, multi-generational interventions. The effective interventions are based on theories of gender and social empowerment and have a view that behavior change is a collective rather than an individual process. And they foster positive interpersonal relations and gender equity. More effective interventions have been group-based using participatory learning methods for both adults and children. And they emphasize empowerment, critical reflection, communication, and conflict resolution skills. With children, age-appropriate design is important, particularly longer interventions. Short interventions don't work with children. And it's a really key message. Carefully designed and user-friendly manuals and materials supporting all intervention components to accomplish goals are really important. And it's essential that we integrate support for survivors of violence. So what about the implementation factors? The key factor is the optimal intensity of the interventions. The duration and frequency of sessions and overall program length enables time for reflection and experiential learning. It's essential that this is long enough and that there isn't too long a gap between sessions. It's also essential that staff and volunteers, who really are the powerhouse of all our work, are carefully selected for already having gender equitable attitudes and non-violent behavior, and that they're thoroughly trained, supervised, and supported. Next slide. So the key question is, when we work in a context of COVID, what do we need to take into account in our work? Can I have the next slide, please?
It's slightly delayed. It's coming up, Rachel.
Sorry. Well, I think the one thing that has become the buzzword for us all this year is around safe delivery of interventions for participants and for staff. So firstly, it is essential to pick up on the message that support for survivors of violence needs to be integrated into interventions being provided. We need to ensure that we are providing this as part of the interventions, not only because that makes the intervention more successful, but because in a context where we're concerned about escalating violence, it's absolutely essential that we have survivors centrally placed within our interventions. We need to Look at issues around staff training and support and supervision, because staff are so important. And recognising the fact we can't put them at risk in terms of preparing them for delivering interventions. We need to look at the use of new technology, using Zoom or blended Zoom with in-person work. We need to look at how we recruit participants via social networks, accepting the fact that there are inherent risks in having mixed networks, and the more mixed they are, the greater the risk. So using established networks, social groups, or trying to identify participants because they've contacted a helpline or a community organisation because they want help. It's really a much safer way of working at this time. We need to look at how we deliver interventions. Blended delivery in using phone or Zoom as part of the intervention may be possible, particularly with psychotherapeutic interventions. There's been a lot of research recently around delivery of psychotherapeutic interventions via telephonic contact. And I think that's something that we really need to take up and build upon. If we're meeting face-to-face, small groups are much safer, particularly, as I said, if they are from one network anyway. And if we have larger groups, we do need to work with caution. Obviously, masks are compulsory. We need our hand sanitizers, our distancing, and to think about ventilation. Well-ventilated spaces or outdoor spaces become particularly important so long as they can be private. And we also need to think about how people access spaces, particularly because of the risks of using public transport. We need to think about screening before people come in for COVID to make sure that we have protections optimized. And we need to build a spirit of connectedness, because one of the things that's been so undermined through lockdown has been the connectedness. And it's really important that we do that, but we can use new technology to assist this. Next slide. So I want to conclude that addressing risk factors exacerbated by COVID is particularly important, poverty and mental health. It doesn't mean that we mustn't address everything else as well, but we need to fold in elements of addressing poverty and particularly supporting and trying to assist with mental health problems into our interventions, which are addressing patriarchy, gender equality, because these have been made particularly severe by the epidemic and what we've done in order to contain its spread. All the interventions we use, however, need to be effective, and this is not the time to say that because we have a huge problem of intimate partner violence, that it's a free-for-all and that we must just go out and do things. What we do needs to be effective, or if it's a new intervention, it needs to be properly evaluated. Innovation is needed for basic safety. We need to know about how we can do things in a way that are effective and a way that is safe. And we need to go out there and do that and test that out in order to learn. And we need to follow the essential elements of design and implementation, because these again remain important. And just because we're dealing with a situation of escalating violence, we mustn't forget them. And we may need creativity to make sure that they're all followed safely, but we can think around these issues to make sure that the essential elements are still included. I think the bottom line is we can't afford to lose momentum in intimate partner violence prevention at a time when the crisis is exacerbating the problem. And when we're poised for action, we have more knowledge than we've ever had before about what we should be delivering that can reduce violence and about how to do it really well. And we must capture this moment to go forward and do it, just as we're faced by the challenges of this massive global pandemic. Thank you very much.
Thank you so much, Rachel, for that. That was fantastic. I think it's highlighted so many things for all of us. The one is that we need to continue to remain passionate about the fact that prevention is absolutely essential, and that we can see from the repertoire of interventions that we have that it's absolutely possible. And so we are well equipped to be able to deal with violence against women and girls while taking into account some of the realities of the current COVID pandemic. And I think you covered that excellently. The other thing that struck me, Rachel, was the synergy between what we heard from Pinky around needing to deal with some of the structural factors as drivers of gender-based violence and how people were experiencing that in the COVID reality. I think that's particularly important because the work that you've showed from comes from a really strong evidence base of having done and evaluated prevention interventions, and then getting the other perspective from Pinky, which brings those two together as almost a confirmation of how we should be poising ourselves to address key drivers of violence against women and girls. So thank you so much for that, Rachel. I said at the beginning that the Gender and Health Research Unit has a very rich history, and part of that history that we're extremely proud of is conducting and research and collaborating with leading gender-based violence NGOs and practitioners in the field, both in South Africa and globally. And we're very privileged today to hear from two of those leading practitioners. The first is Mr. Dumisani Ribombo. Dumisani is no stranger certainly to the South African community of gender-based violence action and prevention. He's a community activist with experience in gender-based violence, HIV, and HIV prevention. And he considers himself an ardent research interventionist. He has been a part of research initiatives as much as he has been at the forefront and the coalface of gender-based violence practice. And he counts his 3 years of service as a member of the MRC Ethics Committee as having helped him to implement and maintain programmatic activities of 3 randomized controlled trials, including the recent Change trial in Diepsloot here in the west of Johannesburg as part of the What Works to Prevent Violence Against Women and Girls global program. Dumi is now director of his own NGO called Yanani, where he works in Gauteng and Limpopo to prevent GBV, HIV, and AIDS, and a new focus, obviously an evolving and responsive focus to a reduction of youth unemployment, as he sees this as an essential part of addressing structural challenges in the broader developmental agenda. And we've heard this afternoon the importance of recognizing and addressing structural factors in the fight against gender-based violence. So I want to welcome Dumi this afternoon. The second person, next slide, please, Patrick. The second colleague and practitioner who's joining us this afternoon and who we'll be in conversation with is Laura Washington. Laura is also a very dear colleague of ours in the field of gender-based violence and has been a strong collaborator with the Gender and Health Research Unit over many years. She is director of Project Empower, and she has overall responsibility there for developing the strategy of the organization in line with its vision and its mission, for resourcing its activities, and for developing and maintaining relationships with stakeholders. Laura is a trained teacher, although she's worked in the NGO sector for many, many years, and she has a deep commitment to the development of individuals and communities, and enjoys working for Project Empower because it contributes to enhancing the lives of young people, and especially young women. And I can bear testimony to the fact that Laura values hard work, commitment, and the enthusiasm of her colleagues. We're very privileged, and thank you, Laura, for joining us. So we're now going to turn to a conversation with both Dumi and Laura. As practitioners who have been at the coalface of prevention of gender-based violence in South Africa, particularly during this COVID pandemic, we'd like to hear from you, and I'll go with you first, Laura. What do your program beneficiaries, what do you think they've needed since the start of the COVID-19 pandemic and its related restrictions to help them to prevent it?
Okay, good afternoon, and thanks, Leanne, for the kind words, and to yourself and to the entire team for the opportunity to just put some thoughts into the discussion this afternoon. So our program, Project Empowers beneficiaries, our program beneficiaries are largely young people living in informal settlements around eThekwini and more recently in rural areas as well. And I think that their needs are pretty much the same needs that they have always had, but of course, as so well outlined by Dr. Matlangu and after that by Prof. Jukes, exacerbated by COVID-19. So we've got like massive material deprivation, and of course that's noted as a driver of gender-based violence. Emotional problems, anxiety, depression, post-traumatic stress, which I think is also going to be exacerbated by COVID. And then the social isolation that COVID has brought upon all of us, where people, I think, have been quite active within their own communities, but have been separated from friends and families in neighboring communities, in communities in the province, and in many cases, from family members that are resident in other provinces. So I think that's all eating away at the soul of people. And I think one of my concerns is that all of these additional, well, the sort of the worsening and exacerbation of these deprivations is going to mean that the agenda of preventing violence against women takes a further back seat. We've done no prevention work since the start of the epidemic, so we've already lost 5 months. But I think that the material concerns of people in informal settlements are really going to be highlighted, and less attention is going to be possible on the prevention of violence against women agenda.
Thanks, Laura, and that's thank you so much. So that's a very interesting and somewhat scary reality that we're facing, is how in a country that where we are facing huge high levels of poverty and inequality, that it really does go down to basic necessities and needing to have basic material needs met first. And of course, the mental health consequences, which seem to be coming across quite strongly as a theme throughout this webinar. So thanks for sharing that. I'll circle back to you in a minute. I want to turn to Dumi, and Dumi, if you can share with us your experiences working in the Limpopo and Gauteng provinces of what your program beneficiaries have needed since the start of the pandemic.
Sure. Thanks, Leanne, and good afternoon, everyone. So in terms of what we have seen in Gauteng and in Limpopo here, one thing that was common across the 2 provinces in our small scale programming was the need to have food by our beneficiaries. We ended up even having to provide food every Friday, a cooked meal every Friday. You could, before you arrive, people will be lining up, and we just saw the need to do something around that line. Second was, the inadequacy of a quick response to GBV reports that were perpetrated. So we found ourselves helpless. One, you couldn't call, the person who tried to call you and reported the case back, because you don't know if you are putting them at risk or not. Yeah. The referral systems remained poor in Limpopo. They were just next to none. And living with the unknown of what would have happened to the victim was very, very challenging. And lastly, I think I would say something that, cut across the 2 areas also was lack of, information in terms of, people getting reliable information about COVID-19 and other things, because people would take whatever that was circulating in the social media and took that as truth, and that perpetuated stigma and fear. So I would say across the two regions, we saw these three as top of the list.
Thanks, Dumi. So when you talk about the two regions, are you referring to the Limpopo province and the Gauteng provinces? Okay. I think I saw a yes, because you muted yourself there, Dumi.
Sorry.
Okay, yeah. So that's interesting because you have, I know in the one area in Yanani, quite a rural community, and then in Gauteng, I would imagine an urban community. And so you're saying these were similar kind of issues that were faced across the two, is that right?
That's correct, yes.
Yeah. So very interesting. The one thing that struck me is your need to be able to have to provide food and a cooked meal to people. Is this something that you started doing at the start of the pandemic, or is it part of your routine intervention work that you do?
This is something that we started during COVID-19. When the lockdown was eased a bit, and we could, obviously we had the license, and when we could go a bit around in the communities, we found this huge need for food, and we just thought, let's provide the little that we could.
Wow, that's amazing. Thanks so much for that. I'm going to move on to the next question. And that is, it was partly covered, I think, in this first question, but was there anything in particular about the national lockdown to you, Laura, and social distancing in particular that affected how you provided services? And whatever services those were. So talk us through a little bit about your experience under COVID in terms of service provision.
Thanks. I want to step back a little bit away from what was actually happening in communities and have a look at what was happening in Project Empower, because I think in many ways, like coming from an NGO, we're kind of like the informal sector of this whole big implementation machine.
Yeah.
And we have also been quite severely impacted, I think, by COVID. And I'll tell you a little bit more about our thinking around that.
Mm-hmm.
So as I said, for the last 5 months, we haven't had any prevention programs being implemented in the communities that we work in. And it was quite a sudden withdrawal. That wasn't just because of the lockdown regulations and the need to stop having physical contact with people. It was also because we were in the process of transitioning between contracts, and we had a series of contracts that came to an end at the end of last year, and we were expecting new contracts to be formed in around the end of February and March, and two at least that would have been large-scale rollout prevention implementation around eThekwini. And both of them disappeared into thin air. We just didn't get the contracts. We couldn't find out why. There was no communication between us and the people that we were negotiating the contracts with. And as time wore on, I began to realize that it was because of COVID and because it was kind of pointless from the mind of the contractors to sign up a contract when we had 5 or 6 months of social distancing ahead of us at least.
Mm-hmm.
So, and then a further contract, a smaller contract, but the signing of that was delayed, and that was based in the US, and it was simply because of the lockdown there. And the reason given was that the people who were designing the contracts just couldn't get into the office to do it, so they didn't do it. So that's 2 contracts lost, 1 seriously delayed, and funding for a further contract that we're busy working on at the moment has also been delayed. We haven't seen those funds yet. So I think the impact of COVID and the associated lockdown and all the sort of ripple effects of that are impacting seriously on communities and on the prevention agenda within communities, but they're also impacting on NGOs like Project Empower, we're struggling to stay afloat. We have eaten into the meager cash reserves that we've managed to accumulate over 20 years. We paid staff, tried to keep staff on during the intense part of the lockdown. We've subsequently had to retrench people. So we've lost capacity there. And as you know, the capacity to implement prevention programs is not something that you learn at university or get a certificate in. It's something that's built up through like many years of practice and mentoring. So yeah, that's the impact on Project Empower and the impact on our implementation of programs in communities. And then the discussions that we have been able to have around future implementation. I think we have a concern that we're going to have to fight very strongly to justify and retain the intense group-based approaches that we have developed over time, and for which the evidence base exists, and for which the evidence base, So there are some actors in the scenario who have asked us, like, how are you going to use WhatsApp to deliver the intervention? And at very best, as Rachel was outlining so clearly, we are going to need a blended approach, to use Rachel's terms, but none of those blended approaches will be able to substitute the face-to-face relationship, deep personal interaction that has been so effective in the prevention programming that we have implemented to date. And add on top of that the perils of internet connectivity and even telephone connectivity in the South African context, data being extremely expensive, and then once you've bought it, it's extremely unreliable, as even those of us on this call are experiencing today. So we've got a whole set of challenges that are facing us. Is if we reduce social contact and go for virtual contact, we're still faced with a whole set of other challenges. Yeah. So I'm not one to give up easily, and I think that we are all feeling quite excited about the challenges ahead of us, but I think we do recognize that they are intense challenges.
Thanks very much, Laura. I think, we nothing if we're not innovative. And I think a lot of us on this call have been confronted with the need to start to become innovative in this COVID reality. It's really sad, I think, to hear about how far-reaching the consequences have been, both for the day-to-day running of an NGO like Project Empower, and also how that has had a ripple effect on communities. And I'm sure that your story is not unique. I'm sure there are a number of people who have either lost contracts or have had contracts delayed and have in the process had to lose staff, etc. And I think it's something that as a field we're going to have to confront and come up with ways to address. But yes, it certainly has changed, the way we do programming and the way we ultimately impact on the lives of communities. Dumi, I'm going to just turn to you very quickly and ask you about how Laura's talked about not really being able to do too much service provision or any prevention service provision during this time. Have you been able to be more successful with that during the national lockdown and social distancing? And how has that affected your service provision?
Not at all. So firstly, I think with the 21 days hard lockdown, we had to withdraw our launching of the program in Limpopo, though we were doing some work already there. And some of the, crowd funders demanded their money back that they donated for the launch. So that was one big loss there. Second was we had a consultancy, which I did personally with AB and Bev, where we're looking at the issues of safe rides and how we can cap, excessive drinking in South Africa to be a research study in Alexander, and that also was halted, and that consultancy was feeding into the programming in Limpopo. So yeah, that took a knock as well. In terms of work on the ground, we couldn't anymore conduct workshops or door-to-door activities. In Soweto, we could do some work visually, but you had to provide airtime and data. It didn't really work well. In Limpopo, there was a misunderstanding of the COVID messages from different people, especially by the gatekeepers. For an example, for them, we were not considered as essential service providers. To them, essential service providers were just government employees only. So
Wow.
they wouldn't allow us to walk around, and try and meet with people, because we are strong in, physical meetings. There was also the issue of stigma. For the few chiefs who understood and allowed us to work, we met a new challenge where some beneficiaries didn't want to meet with us because they thought we're bringing COVID-19 to them. So
Oh, yeah.
we couldn't do work that way, yeah.
Yeah.
Others, I think we also found that in Limpopo especially, people thought, COVID is more in Johannesburg and Cape Town and in Durban, they're immune to it. So there was a lot of ignorance. To this day, I think we still see people just walking around carefree and so forth. And then because of the hard lockdown, some people in the villages resorted to making the home brewed beer. And when the soldiers or the police would come, they would spill that over, and they thought we were spies. When we went around the villages. Yeah.
Very interesting perspectives. Thanks for that, Dumi. I'm going to have to draw the question and answer session to a close very quickly, but I do want to leave you both with a final challenge and question. So on one hand, we've heard from Rachel and Pinky about what the needs are, what the drivers are, and what necessary steps are that we have to take. But we've also heard about some of the real challenges of people like yourself, Dumi, and Laura on the ground, who've really been struggling to get across these services. COVID is going to be with us for quite a while. It's a reality that we're all slowly starting to accept. And so my question to you both, and perhaps you could go first, Laura, is how do you think we need to adjust our service provision? For example, with group-based programming and gender transformative programming that requires both group and individual or couple interventions. How do you think we're going to have to adjust some of our approaches in order to make sure that we keep prevention on the agenda?
Thanks, Leanne. I'm just quickly from my side. I think that a lot of the potential solutions have already been mentioned. We've just got to get to grips with the virtual stuff and figure out how to use it and how to make it work for our participants, and also figure out when is that the appropriate platform and for what kind of content is it the appropriate platform, and then how we can also make the interactive social engagement and interpersonal engagement more possible. And that's probably simple enough. Smaller group sizes, more use of open space, going to be difficult in Durban and informal settlements in the rainy season, for example, but in some contexts it's going to work a whole lot well. We've just got to build in experimentation into our practice and figure out what works. Thanks.
Thank you so much, Laura. Dumi, a final word from you.
Of course, I think for me, I would say for both prevention and response to violence against women and children, or GBV in general, should not remain the same. One, if we think of the messages I've been using for years and years, are they effective? I think COVID-19 has taught me to reflect more and say, are these messages reaching the targeted audience? Are these messages really hitting on patriarchal tendencies to break those walls. For instance, if I said enough is enough, that's a message. We have said it again and again. Is it effective? If it's not, what new messages can we put in place? As an example, the issues of, you know, us having to distribute food just said to me, you need to add issues of economic empowerment in your programming. Even if you don't do it yourself, who do you partner with as you continue doing the work? And how do you continue doing local government advocacy on GBV in general? Because COVID, in my view, made or brought a shift in focus. You saw people just focusing on COVID, but yet people are still living with HIV. They needed to access the clinics. GBV was rampant. We have seen that. So, yeah, I think Laura said it, blending. So we challenge to blend our programming to respond to the needs on the ground.
Thank you very much, Jimmy, and thanks to you, Laura. I think we can listen for a long, long time and continue with conversations, but we are limited by time. I want to say thanks so much to both of you for sharing your insights. I'm going to hand over the session to Dr. Nwabisa Shai. I know a lot of you have been typing your questions in, and if you haven't, please use the opportunity now. We're going to take a few questions so that we can respond to them. Over to you, Nwabisa.
Thank you, Leanne. So what I have here is two sets of questions. On the chat box, I think that two of the questions have been answered and only one left over. And then there is a general question that's related to the last conversation we've had. So what I would like to do is to go through perhaps the questions on the Q&A block first to see if Pinky and Rachel would respond to those questions and invite them to respond to those questions, and then go to the last two questions I see on the chat box. So Pinky, I know you have had some time to have a look at the questions around the motivations for doing research under lockdown and some of the methodological and ethical issues that you considered, and I hope you are ready to respond. I'd like to start with you, please.
Thanks, Nabi. So we opted to conduct research while participants were still under lockdown because we wanted to catch them while they can still recall their experiences. If we waited longer and longer, we felt that, you know, most of them might not recall as much as now. Also, just to clarify that we did telephone interviews. We did not interview people on WhatsApp. WhatsApp was only used for people to send their written consent. And yes, we did send them data bundles. We also send them SMS bundles for those who did not have WhatsApp. So we did not only communicate with them via WhatsApp, but we also used SMSs. Yes, I think I've responded to the questions. Those were the main questions I think that were asked, Nwabi, unless I missed something.
Thank you, Pinky. I believe you have, because you also responded on the chat box to Nops's question. So now I would like to invite Rachel to address questions around the kinds of data that we currently have. So on the chat box, the specific question that has been asked was whether we know of any prevalence data similar to the kind of data that has been, that you discussed in your presentation around levels of gender-based violence, and whether, you know, are we seeing whether there is an increase, for example, around GBV data that's reported by NGOs. And I would like you to maybe combine that with the questions around reporting of police and army brutality, and also the hypothesis around what happens with what happened with male-on-male violence. Over to you, Rachel.
Well, I think that research under COVID has been really limited, and that these initial findings that Pinky shared with us today have, they really are some of the first research findings that have come out about people's experiences of their lives during the COVID pandemic. So the sources of data we've got are really reports from that we're all reading in the media. And we also have the police reports, and the statistical period we've got available only coincides with level 4 and 5 in any detail. So I think our sources of information are a bit unreliable, or they're a bit limited. And the service providing organizations as well do have a sort of handle on the number of calls or requests for assistance that they get. But given that they normally are only providing assistance to a small proportion of people who experience gender-based violence, again, it's not a very good way of really getting a handle on what's going on within communities. So I think that for us to really understand what's happened under COVID in any great depth, what we need to do is to wait until we have research on that. And there is work planned, and the Gender and Health Unit is going to be doing work to try and understand what's happened to femicide next year. And there will be other research that's looking at other forms of violence, but we don't really know in any great detail what's happening, from a general sense that the problem has got bigger. Has the problem of all violence got bigger? Well, I've shared with you the fact that we don't think that rape has increased. In fact, it's probably reduced. And on the chat box, I'm asked whether that might have been the case with male-on-male violence. And I'm sure that it has been reduced. I'm sure that that will be reflected in the fact that the police murder rate has come down so much, because the majority of people murdered in this country are men killed by other men. And so I do think that that's likely. I'm not quite sure what lessons there are for the future from that, because I think all of us hope that there never ever will be another experience of hard lockdown in our lives, and we won't have to cope with another pandemic like this. Although I think it's very important for us to gather our learnings from this pandemic in case that turns out not to be the case. And it may be that we will experience future pandemics like the one we've just had. And so we really do need to learn how to sort of cope with the consequences in a way that is less overall impactful across societies. But I think it is very important, and for now, what we know about what's going on is quite limited.
Thank you, Rachel. There has been 2 questions that were also raised about whether we know of any data that's available on the impact of COVID on women with disabilities, or any such data around disabilities and GBV during this period. I think I would give you some time to consider that question while I go to the last set of questions which came up during the conversation with Laura and Dumi. And the question reads as follows. Matodzi is interested in your ideas on what alternatives are needed to ensure continuity in service provision, considering the funding constraints that we have seen with budget cuts in government, and particularly around the scenario of contracts to NGOs as well, and the shifting of budget priorities toward COVID recovery. And another one is
So we may have lost Nwabisa there. Am I the only one who's lost Nwabisa?
To me, yeah, I also lost her.
Okay, so I'm just going to pick up where she left off. And it was the question from Matodzi asking about what alternatives both you and Laura think would need to be considered to ensure continuity of service provision, and whether we should be looking at government budget contracts further, given the funding move to COVID recovery. And quite rightly so, Matodzi says there seems to be a disjuncture between the realities on the ground as you've experienced them and have just shared, and decision-making processes. And any thoughts on how we can address that to support the integration of people's experiences? So I will let you, either of you can choose to go first, either Laura or Dumi.
I can go first. Thanks, Matodzi, for that question. I think it's a challenge for me, perhaps for NGOs. When we use the language of blending in our programming, I think we need to think of how we blend, funding strategies so that there should be continuity of the important work on the ground. As we think of how we can integrate economic empowerment into our beneficiaries, I just thought I am challenged to think of ways in which the same or similar economic programming should be in line to try and fund work on the ground so that you do not Sorry about that. You do not just rely on funding from donors, but the seed funding within the organization. I think NGOs going ahead.
Great, thanks, Dumi. Laura, do you want to respond to that? Laura? Okay, Laura is on mute. Nwabisa, I see that you're back. Do you have a further question?
Hi, hello, I'm unmuted.
Go ahead, Laura.
Can I quickly? Okay, I wish I had some quick, easy, effective, immediate, implementable solutions to that, but I think it's going to take a lot of effort. We've fought hard to make this space where prevention of violence against women and girls has become a priority, and we're going to have to fight really hard to keep the space open. I'm very mindful of what happened when the HIV pandemic became an established fact of the global landscape, and funding from governments and from non-government donors just poured into HIV and left all the other agendas like completely unresourced, and everybody started focusing on HIV. We can't let that happen. We've got to defend the space that we've created around prevention of violence, and if anything, we've got to expand it. So I think it's going to take a lot of activism, a lot of advocacy from all of us in all of our different domains. Thanks, Leanne.
Thanks, Laura. Back to you, Nwabisa.
Thank you, Leanne. And just to sneak in one last question from Nobs, and she's asking whether those participants who reported, she's asking Pinky, whether those participants that reported positive experiences during lockdown, do we know what the drivers of their experiences were perhaps? Pinky, I don't know if you are able to respond right now, but I'm also noting that we are 1 minute over.
Thanks, Nabi. I'll be quick. I think positive experiences were noted across SCS groups, even amongst those who were in the low-income group. They did appreciate the time that COVID gave them to be able to spend with their families. However, most of them were in the high SCS who indicated that outside of COVID, many of them do not have time to be home as much as they've been during COVID time. But this was across really, and it's really difficult to identify the particular drivers that NOPS is referring to.
Thank you very much, Pinky. And I think that we have run out of time. I'll hand over to you, Leanne, and I will note Celine's question. Hopefully we can respond to her.
Thank you very much.
I think it's a comment, so it's fine.
Thanks, Mobi. And thanks to all the panelists for responding to the questions. I think it does remain for me to say a very big thank you to, firstly, all the panelists for sharing both their research and their practice experience with us. I think this webinar has left us with many questions, but it also has confirmed for me, and I'm sure for many of you, that we need to continue to fight with vigor and with passion for the prevention of violence against women and girls. It's something that many of us on this call have dedicated our lives to and continue to do so. But we do need to do that, thinking about things much more innovatively and creatively as we move forward. I also think that this coming together gives us all an opportunity to also connect with each other and to share experiences like this. And we hope that this, one of the first, I think, South African studies done will begin at least to direct us to new ways to do research, to new methodological concerns, and also to new ways of practicing gender-based violence prevention and response. So I want to, with that, say aluta continua. That's what we do here in South Africa. We're always continuing the cause, and to say thank you very, very much to all of you for attending. Our websites are up for both the Gender and Health Research Unit as well as the What Works website, which Rachel referred to for a lot of the reports. But to all of you, thank you very, very much, and please stay connected. And a good afternoon to you.